Doctors really want their patients to do certain things and really do not want to see a large number of barriers in front of them, because we know how hard it is to get people to go to their appointments, to get their tests, and to take their drugs. Certain drugs that I would put on the list are those to manage chronic conditions that have proven to be effective, both in terms of health as well as economic implications. Drugs that lower blood pressure, that impact diabetes mellitus, that lower cholesterol, that treat asthma, depression, osteoporosis. There are several conditions out there with proven effective therapies, with strong economic analyses that are markedly underutilized, and frankly, in my opinion, there should not be a large financial barrier inhibiting their use. There have been a lot of research studies looking at various copays for various things, and it should not surprise most people that even when you put a small financial barrier in front of them, they'll stop spending their own money, even on important medical things. All research to this point has showed that individuals will not buy important medical services, even if there's a small financial barrier, $5 or even $2. This study showed that when we removed those barriers, people started using these high-valued services significantly more. Well, I've always been interested in the way people respond to small changes in price, and whether if we lowered copays for certain things or raised copays for other, how people would respond. My mother turned to me and she said, "I can't believe you had to spend $1 million to show that if you make people pay more for something, they'll buy less of it." Well, it turns out there are many skeptics in the community, and we needed to show with a carefully done study that if we did lower barriers, that people would utilize these essential medical services more. And as always, my mother was right. The reason why this study is so important to us is that we used two different employers where everything else was going on the same except for copay reduction. And clearly what we found is in that employer that had reduced copays, the use of the important drugs was higher than in that other firm that did not. The most important thing about this intervention is we're really trying to improve the health of these employees. We do, of course, have to talk about the cost implications of lowering these copays. We believe that these services in particular will pay off in terms of reduced hospitalizations, emergency room visits, and maybe more importantly, better productivity on the job and lower disability. While future studies need to be done to actually quantify this specifically, we really do believe that this is a fine investment and copays should be removed for these high-valued services. There have been a number of champion employers who really felt that it was a good idea to lower copays for high-valued services, but there's never been a study that actually controlled one employer to another that did not do the same thing. So the presence of a really rigorous study in the literature for us really should get many employers and payers over the hump, and we'll hopefully see more of these clinically nuanced benefit design situations available to patients and individuals in the near future. We're fighting hard to get individual employees as well as many small employers to understand that we need to go away from the cost discussion and back to the health discussion. And the more we think about health, the more we probably should push for benefit design programs that do not only look at the lowest cost intervention, but the one that produces the most health per dollar spent. It's nice to see, since we published the concept in the late 1990s, that there is a fair bit of momentum. Pitney Bowes in Connecticut adopted a program similar to this several years ago, and now we have a large number of employers such as Eastman Chemical, Procter & Gamble, and the University of Michigan who've adopted a value-based or clinically nuanced benefit design. It is our hope that more insurance companies like Aetna, Cigna, WellPoint, the Blues will see the value in this type of design and offer it soon to its beneficiaries. One of the most interesting is my own employer, the University of Michigan, has implemented a value-based design situation where our 2,000 or so employees and dependents with diabetes get many of their essential services either free or at markedly reduced cost. This includes eye exams and foot exams, as well as several important medications, such as those to manage their blood sugar, as well to manage their cholesterol, their blood pressure, and depression. I think there's way too much attention being paid now just to the cost of health care and not the reason why we're providing it. That is, improving employees and their dependents and the retirees' health. It's critical at this time, in my opinion, to restore health to the healthcare cost debate.